Hello and welcome. I am Pascaline Dupin. I'm a development economist with a focus on policies aimed at reducing global poverty. I'm a professor of economics at Stanford and also the faculty director of the Stanford King Center on Global Development, hosting this event. Thank you for joining us today. Before we jump into the discussion, I want to share a little about the Stanford King Center on Global Development. Our goals here at the center is to turbocharge research to alleviate global poverty and to make sure that decision makers around the world have the information they need to implement effective policies and programs on critical development issues. This requires a multiplicity of disciplinary approaches, and so that's why the center supports scholars from all 7 schools around Stanford and facilitates student opportunities both on campus and abroad. This brings us to our conversation today, discussing the pandemic surge in India. Today's discussion is going to be recorded, and the recording will be available on the King Center's website early next week. Thanks to all of you who shared questions when you registered for the events, and please use the Q&A feature to ask questions in real time. Let me now introduce our speakers. First, I'd like to introduce our main speaker, Dr. Ramanan Laxminarayan, who is the founder and director of the Center for Disease Dynamics, Economics and Policy, and who for the most part of last year has been in Delhi working on COVID relief. He's the founder of an initiative called Oxygen for India, a volunteer-run campaign to deliver life-saving medical oxygen to those who need it the most as quickly as possible. And we are most grateful to Dr. Laxminarayan for accepting to speak with us today. We reached out to him in the peak of the second wave, when many of us on campus were feeling distressed and helpless and felt that we needed guidance on what we could do to help. And Dr. Laxminarayan was in the front line at the time, helping deliver oxygen. So, we are very gratefully agreed, but we agreed it would make sense to schedule an event a little bit after, we had passed the peak. So it seems that we are now past the peak, but hopefully we'll hear from you today whether we can trust this data. Now, let me introduce our moderator, Dr. Arvind Krishnamurthy, the John Osterweiss Professor of Finance at the Stanford Graduate School of Business and a King Center faculty affiliate. Professor Krishnamurthy studies finance, macroeconomics, and monetary policy, and he has studied crises of a different type, liquidity crisis in emerging markets, and the role of government policy in stabilizing crises. Thank you both so much for being here. Arvind, the floor is yours.
Thanks, Pascaline, and thank you, Raman, for making the time to have this discussion with us. We look forward to hearing your insights about this. And I'm just going to moderate this this discussion, and mostly I'd like to hear from you and also follow any audience questions as they come through. So I thought we'd break up our conversation into 3 bits. One, just talk about what the situation in India is currently and how you see it. And then talk a little bit about some of the interventions that India has taken, how you've seen them, and then how you might like to have seen them. And then last, talk about broad lessons for the future for both India as well as other developing countries in dealing with health crises of this nature. So let me just start. I just looked at the Johns Hopkins numbers for last week. The COVID case count was 630,000. COVID-related deaths last week were 23,000. I don't know what the underlying source of this data is, and I just wonder if you can speak a little bit about what the current situation in India is, where you see particularly undercounts, how it's affecting different demographics, urban versus rural, and where we are relative to the peak of the wave. Right.
So thanks, Arvind, and thanks, Pascaline, for organizing this and the King Center. India is in an interesting position. It had the first COVID death on March 14th of last year, the first recorded COVID death, although there were certainly COVID deaths in India prior to that. The first reported case was in a student coming back from Wuhan on Jan 30th on a chartered flight. And the 3 students were isolated, and it's probably, there probably wasn't secondary transmission from those cases, but this probably was other transmission happening in India already. And over the period of 2020 into 21, there have been 30 million reported cases, 380,000 reported deaths, And a third of these have roughly been in Maharashtra, just one state. So again, given India's size, 1.4 billion people, we have to remember that a third of these are reported just from one state, which is a state of over 100 million people, and probably only less than a tenth of India. And Maharashtra itself is unusual in being the most urbanized state in the country, with the exception of New Delhi. It has a strong health system, it has strong reporting, and that gives you a sense for, if a third are emerging from a state which is roughly a tenth of the size, what are we missing from the other states? Now, so far, from a global context, India has about a sixth of the world's cases, reported cases, and about a tenth of the global deaths. Now, and we're sort of at the end of a second large wave, but we have to remember that we're not completely down yet. The 6-day moving average is still at about 80,000 cases, and that is not too far below the peak in mid-September of last year. So where we are now at the bottom of the wave is still close to the peak that was seen at last September. Now, India ranks 109th in tests per million globally, so nowhere near the top. It ranks 107th in deaths per million population and 105th in cases per million population. Now, the only thing to keep in mind is that, I know everyone there is academic, but the interest here is really in communicating numbers and interpreting them in a way. And I think it's never productive to see these as, how has India performed, as if India was some unitary system, or some reflection on or India or Indians or anything of that sort. I've seen a lot of suffering in India over the last year, particularly in the last 8 weeks or so. And I'll say I've seen amazing things happen there with respect to response. I've seen some terrible things happen there with respect to response. And that is not unusual for India. That has been true in the United States as well, and true for many other countries. But India, everything gets complicated, because of just the sheer size and diversity of the country and the challenges in governing a country of that size. And of course, not to speak of the population itself, which has its own challenges with health, even in the best of times, let alone during a time of a pandemic, weak health system, and so forth. So first, let's start with the numbers. Now, I gave you an overview of where the numbers are. Now, India has almost certainly undercounted both cases and deaths. Now, on the case side, typically we look at the ratio between what you find as a number of infections as determined from seroprevalence surveys, which measure what proportion of the population has been exposed to the disease, and divide that by the number of actual reported cases to see what the level of undercount is. Now, when the Indian Council of Medical Research has done these sorts of studies, the extent of undercount has been anywhere between 15 at the very lowest, but typically between 26 and 32. So in other words, by the government's own estimate, about 1 in 30 actual infections are recorded as reported cases. We're missing 29 out of 30. Now, that number may not be 30, maybe it's 25, which is a number I believe a little more, given that seroprevalence surveys are not, were not accurately representative of the country. But still, to miss 24 out of 25 infections means that a lot of infections have actually been missed. And so if you multiply 25 by 30 million, you arrive at a staggering number of 750 million cases, which is a lot of cases. And that's true, but given India's size, that's about half of India's size. So again, you're going to see very large ranges in these estimates simply because of the much larger uncertainties. If you're dealing with a population of Rwanda, 2 million people, you'll get much closer estimates than you would in a country the size of India, where you can bury so many Rwandas right in there. So cases have almost certainly been, underreported. My best guess would be that we have about 600 million cases of this infection so far to date from the start of the pandemic. That would be my best guess. Some of these numbers made their way into both an Economist piece that came out last week, as well as a piece in the New York Times on the number of deaths in India and cases that I think came out about 2 weeks ago, which a few of us were helped inform. And I think the best case estimates, again, for number of deaths would be about 1.6 to 1.8 million, which is roughly about 4x or 5x that of the reported number of deaths. Now, is that level of undercount unusual? No, because India is a country where even at the best of times, only 1 in 5 deaths is medically recorded. Add to the fact that testing levels have been poor and unavailable and inequitably distributed. Much of the testing, which I'm referring to, is actually in urban populations being tested for things like taking a trip somewhere or getting on a flight or going somewhere or for the workplace or things of that nature. Most of the tests are not necessarily for people who are symptomatic or asymptomatic or think they might have been exposed to someone else. There was a stage when those accounted for the bulk of the testing, but that is no longer the case. And this has changed quite a bit. So that's as far as the efficiency of the testing goes. Now, the other part is also with respect to incentives. Now, clearly, different state governments are competing with each other to show that they have the fewest cases. The ones with strong health systems are less able to fudge numbers because, you can't destroy a good health system in the middle of the pandemic either. And so those states are the ones where you'll consistently see high numbers of cases and deaths. Those will be Tamil Nadu, Kerala, Karnataka, Andhra Pradesh, Maharashtra, to some extent Punjab, Delhi, and so forth. So you see worse epidemics in these places, and one can try to correlate places with weak health systems with with lack of water and sanitation, and somehow arrive at this mistaken notion that poor health performance in the past has been protective towards COVID. I think that's a big mistake. Poor health performance in the past simply means that they don't have the capability to carry out the levels of testing to be able to identify who has COVID. That's really where the causality is. It is not from having a poor health system and exposing people to diarrhea and respiratory pathogens and then having fewer deaths and cases. I think this is surely what's going on in Pakistan as well, and many parts of Bangladesh, which is just that they don't have the systems to be able to do the testing and measurement. And therefore, we arrive at the incorrect conclusion that somehow Sri Lanka is doing worse and Pakistan is doing better. Not true at all. I think it's simply that Pakistan is not measuring. And that's why it has caseloads that are on a per capita basis closer to that of Uttar Pradesh or Bihar, where it's closer in health system capacity than to India's national averages. And I think this is true around the world, which is we pick up things where there is a system that is able to observe them. And Maharashtra, unfortunately, falls into the category for them, from a political optics perspective, of being urban, strong health system and strong reporting, high income and so forth. Similarly for deaths. Now, deaths are very visible to all of us if you're sitting in the US, because when they happen in hospitals, there are bodies leaving morgues, there's a concentration of deaths in particular places, and they get to be observable because there are crematoria that are working overtime and so forth. When deaths are dispersed in rural areas, because there is no hospitals for people to go to, then deaths simply occur at home. And when deaths occur at home, you have to remember that even in excess of 2 million deaths a year, 2 million deaths a year, when spread over the space of 36,000, is only a 20-25% excess. And remember, it's not even spread out throughout the year. It's in some periods of sharp peaks. So you're talking about, India has something like 28,000 deaths, in a day. And so you multiply that, you add another, 5,000 deaths, okay, 6,000 deaths a day. When you divide that by, the 700 districts that India has, you're talking about 10 additional deaths per 3 million population per day. And in a weak health system, would we even be able to pick up 10 additional deaths in a 3 million population per day? Absolutely not, because 3 million population is a lot of people. I mean, that's just 10 deaths that happen somewhere. So unless we have the sensitivity of a system to be able to pick up mortality, we're not going to be able to do it. Now, in terms of where the first set of cases went, because of an early lockdown, India was largely spared the worst of what could have been a really terrible situation last year. I wrote about it on March 28th. On March 22nd, I had warned that, or not 22nd, 19th, I'd warned that we needed a national lockdown and we had projected a very large number of cases and deaths, which were not unusual at all, because the first principle of COVID is that everybody's the same as far as the disease goes. But there were narratives that were spinning around in India and many parts of the world that Indians had BCG, they had higher immunity, they had access to hydrochloroquine, that the heat in India would kill the virus, any number of different sort of superiority arguments or exceptionalism arguments. And of course, there is no Indian exception to COVID, as there is no exception for anybody on the planet to COVID. The only exception you have is if you have a strong health system and strong governance and population compliance, the three things that the foreign minister of Singapore had said very early on, and would be the things that differentiate countries that did well with COVID versus not. Now, the one thing India did do well was put that early lockdown in place with just about 10 or 15 deaths at that point and a few hundred cases. And that was based on these projections that warned that things were going to get really bad for India. And it was a 3-week lockdown. It probably went on for much longer than it should have. But that was because there was a serious lack of sort of capacity to inform and guide how science would drive this. I mean, there were all sorts of nonsensical non-evidence-based recommendations, including hydrochloroquine. Of course, that was partly driven by what was happening here in the US as well with the previous administration. But subsequently, we've also had things like remdesivir or ivermectin or plasma therapy, things that have been debunked in many other parts of the world, come back to really destroy both outcomes for people in India accessing the health system, but also leave them financially impoverished. And that has also contributed to mortality in India, in addition to COVID itself. But broadly, I think last year was made possible as a low COVID year relative to what could have been, simply because of that lockdown. I wouldn't credit anything else except that lockdown. Now, unfortunately, in February or January or February of this year, there was the wrong signal that was taken from the relatively low number of COVID cases. I say relatively, it was still pretty bad. I would estimate that last year we probably lost, maybe 300 or 400,000 people, which is still a lot of people. But the message was that somehow India had conquered COVID even without a vaccine. And there was a lot of, backslapping and chest thumping around this without realizing that, the disease would come back. But the one thing that I had been surprised by was I had expected that, having gone through a tough year last year, that there would be very quick lockdowns this year as well, once the disease started reemerging. And here I was wrong. And I think the biggest thing that has been difficult to predict for COVID is how governments respond to COVID. The disease is relatively easy to model and predict. What is difficult is behavior, particularly that of governments. And obviously, nobody ever thought that there would actually be an actual fanning of the flames of COVID by hosting the Kumbh Mela a year in advance of when it should have been held, of election rallies. And I point to these more than things like the farmer rallies, simply because it is not so much that these are super spreading events in and of themselves. It is more that they signal to the common man that the government believes that COVID is no longer a problem. Now, the common man doesn't take that signal away from a farmer rally, because farmers are protesting, and that's like a Black Lives Matter protest here. It is not a signal from anybody to anybody else. It's just a protest about Black lives. But when the government says, listen, you can have an election, then that signals to everyone that you can stop masking and distancing. I was in Guwahati in Assam in February, end of February this year, and literally, I probably think maybe 5% of people were wearing masks. And that is really what resulted in the second wave. Now, the second wave has been devastating. I think there is no media account that really does justice to it. Maybe the closest is Jeff Gettleman's piece in, just being scared in Delhi. And I think that is that's really that was the overwhelming feeling. I have never seen a time like this. I've had people, rich or poor, well-connected, powerful, all in that same fear, begging for a cylinder of oxygen, which is the rarest commodity at that point in time. It was really something which, you know, I don't think one could ever be in that situation even again. It's just so bizarre and tragic and unusual. A colleague of mine, who's only 42 years old, you know, was in hospital. We had to send teams out 6-7 hours every night to go get oxygen to keep him alive. We were not successful, unfortunately. He died, and we lost his brother as well, 38 years old. This guy had a 5-year-old child. And that's the kind of story that I've seen again and again and again. We used to get these calls every hour saying, you know, can you deliver oxygen to this place? And 6 hours later, you'll get a call saying, never mind, you know, they've passed on. And this happened just all too often. And I could talk about oxygen for India in a second, but I just thought I'll focus on the mortality numbers first in response to Arvind's question, and then and take it from there.
Raman, just to follow up on the mortality and the case count, I think what I heard you say is we measure in the cities and we measure in the states with good health systems, and the measured numbers look like they're going down. Is your sense that in the unmeasured places they're also going down, or are we? Where are we in some of the unmeasured places?
You know, the honest answer is we don't have a good idea at all. And it doesn't help that the government releases no actual raw data about COVID testing at the central level. So the state level data for the states that we have show that it's going down. And the only reason it's going down is because there's been a lockdown effectively in place for the last 2 months across the country. It hasn't been called a national lockdown, but it is effectively a national lockdown. So I would say that I would expect it to go down simply because the intervention was put in place.
Yeah. But you also said that something like 50 or 60% of the population has had COVID at this point. That's
probably about it's at 600 million, which would be about 40%.
40-50%. Okay, and do you think that's homogeneous across the country?
No. So the early waves were primarily, and this is our own data, which show that they were primarily in the urban poor and in centers of rural India. So rural India is obviously not just stretches of farmland. You've got rural India with population centers there. So the urban rich were able to protect themselves by going indoors as soon as the lockdown was put in place. And so the earliest cases geographically were in places with international airports, which would be Delhi, Bombay, to some extent Punjab, and then also Chennai. And that's where you saw the biggest growth in cases, and of course Kerala. And subsequently it went into to the urban centers. In the second wave, it hit primarily the urban middle class that came out in large numbers, thinking COVID was over. And I think that they were probably more affected. And then, of course, rural India, and rural India is where 70% of India lives. So you're talking about a population of 850, 900 million people. That's really where I would also say the largest proportion of people who are still uninfected live in rural India.
And with respect to the lockdowns, are the effective lockdowns, have they been urban centric, or are they, I guess density is clearly lower in rural areas, but India is a dense place to begin with.
Yeah, that's the thing to remember. India is dense everywhere. And, although, Delhi is about the same density as New York City, which is why you saw very similar kinds of transmission happening in the two cities. You have to remember that state density is highly variable. There is no rural India density. UP is far more dense than Madhya Pradesh or Rajasthan, as you know. So, but the largest numbers of unreported cases probably are in Uttar Pradesh and Bihar, just because of this combination of the size of the population and the lack of testing and reporting. And I don't know if you saw this, there's been a big scandal now about how about 1 million tests that were done during the Kumbh Mela were just completely fake tests. And so, not unusual at all. In UP, there have been directives that we've heard of going out to district governments saying, we don't want the reported numbers to go more than a certain amount. And in fact, the unusual thing about UP district level is that they sort of cap out at a certain time, indicating that they're not allowed to report beyond a certain point in time.
Yeah. So I guess and my question is partly, are the lockdowns as effective in urban areas as they've been in rural areas, more in some areas than others?
I think they're more effective in dense areas because lockdowns are effectively proxies for masking and distancing, which either because of ability or because of conviction, people are unwilling to comply with, and therefore the lockdown basically forces them to do that. And therefore the greatest impact is going to be in places with higher population density. But what I'm saying to you is that that's not necessarily a rural-urban divide. It's certainly urban, but in rural areas there's going to be significant heterogeneity.
Okay. Take you back to March. You spoke about this a bit. The people felt like the worst was over, and somehow India was beyond, which, as you say, is some sense fictitious. And you emphasize the signal from the government as being a thing that allowed people to move around more. And I'm just wondering, is there data that supports, like in the US, we look at Google mobility data to describe population movement. Was there really could you notice change in behavior as we went from last fall into spring in the way in which people were interacting, which then allowed the virus to take hold?
Oh, without question. I think I remember being in a passenger line, unfortunately, for a flight from Bangalore to Delhi, and to get on a flight, and the airport was just packed in January and February, just packed. Whereas the way it is now, which is similar to what it was last August or September, was there was nobody at the airport. So you went from a place where there was absolutely no mixing to a point where it was just everybody was back, and it was I don't know if I think the airline travel data is really the best indicator or proxy for this, which is you can see from that there was a definite return to travel, which was significant, and so that goes well beyond the Kumbh Mela and all of that, because those, like I said, are not the only events. They are important, but they don't tell the entire story. But I think if you look across India, if you have train and bus and airline travel data, it will give you a very clear idea of when that mixing really started again, which started actually in December and then went through to February or March.
All right. You spoke about the current situation and about the oxygen shortages. I wonder if we can just speak a bit more about that. Should we think of the oxygen shortage as an overall India oxygen shortage? Is it about distribution? What has been the issues with oxygen in India?
So oxygen has been always in shortage, not just in rural India, but also in rural Africa, simply because oxygen is typically manufactured in central sites, which tend to be close to industries, because the largest users of oxygen in India are industries like steel plants and so forth. So the largest oxygen manufacturing facilities are concentrated in, to some extent, Uttar Pradesh, but also East India and West India, Maharashtra. The South and North of India don't have as much oxygen manufacturing capabilities just because of the nature of how oxygen is made. At typical times, only 15% of India's oxygen supply goes towards medical oxygen. The remainder goes towards industrial purposes. However, the demand for oxygen during this last peak went up 10x. So you needed far more than was even produced entirely, even if you diverted everything from industrial oxygen into medical oxygen. So let's say you needed 15 tons and you're only making 100. Actually, you needed 150 tons. So even diverting all of it meant that you were left short 50 tons, which is, every ton is, that's a lot of patients who are left without the ability to breathe. So there was an actual supply situation as well. In addition, there was also a distribution question. And the distribution question was simply that oxygen cannot be airlifted. It has to be moved by rail or road. And the number of tankers that were available for this, even if you diverted all of industrial oxygen into medical oxygen, there is simply not the tanker capacity to be able to move it. And tankers move incredibly slowly. You can't move oxygen at more than 30 miles per hour. And at that pace, to get from from West Bengal into Bihar, for instance, even if it's 1,000 miles away, would take 30 or 40 hours. So that's if they were going nonstop. So there were actual issues, and then there was last mile delivery issues, which is even if it got into a city, patients had no way to get to the oxygen simply because there was no enough cylinders, or the oxygen could be 20 yards away from me, but I would die without it, without a way to get it to me. So what we saw with the oxygen crisis was a reflection of something that happens because of weak health systems, even at normal times, where pregnant women, children with pneumonia, patients with who've been in accidents with trauma, who are losing blood, or patients with respiratory or cardiovascular disease all die because of lack of oxygen. And this is a well-known phenomenon. And then you're exacerbating this with once in a lifetime kind of a pandemic wave, which also demands oxygen. And so it was just devastating and tragic, and it was just heartbreaking being in the middle of that. So we started Oxygen for India basically because of both the short-term need, but also I just think we need to fix this oxygen problem for once and for all, starting with India, but extending into Africa as well, and of course the rest of South Asia. Medical oxygen is one of the oldest medical interventions we know about. We've known about it since the late 1700s, and it's used in modern medicine, goes back to 1800s. And so we know this so well. It's such a cheap intervention, and the idea that it's not available to everyone who needs it, when it literally costs 60 cents or 70 cents to fill a tank, a 10-liter tank with oxygen. That's all it costs to fill it up, and that could last someone for almost a day. 70 cents to keep someone alive for a day seems like the world has enough money to do this.
Mm-hmm. So you're saying just increase the overall supply is the thing that is the initiative you've been involved in.
Increase the overall supply, but also change the last mile delivery. So we've invested a lot in cylinders to be able to bring oxygen to people who need them, and there are many others working in the space now with PSA plants and so forth. But we just need to make sure that this never ever happens again. But there is a real.
And how far off are we on the scaling? How much do you want to scale up on these dimensions, both in distribution as well as total supply?
I think the total supply needs to double. We're not close to that. So the total supply needs to at least double, and possibly triple, because the current supply only meets the need of high-end hospitals and urban centers. If you're in a primary health center or a sub-center in some place in rural Madhya Pradesh or Orissa, you don't have oxygen even today. Now, they may not be part of your 15% demand, but they're a legitimate demand. So, I'd like to see the total medical oxygen supply go up, I would say 3 to 4x at least. We're still scaling this as we and sizing it as we go along. But on top of that, we need to have, so the way we're doing this is we're building a sustainable system where there's regional oxygen banks. We have about 500 PSA plants that can fill these 500 cylinders each. And this is how we're able to get 250,000 cylinders out to people who need them immediately. We just don't want a situation where, sorry, you're in a sub-center somewhere far away, you're out of luck. That is just not an acceptable situation anymore. And I think it should not be an acceptable situation, because today, or whatever, in the last 8 weeks, we saw, everyone with the best connections. You could be the CEO of a major Indian company living in Delhi, and I'm not making this up. I mean, this is a real life example, and you're begging for oxygen and would do anything for it. And I think that people have now realized that this is an issue for them, despite their privilege. And I think we should now solve it for everyone, regardless of privilege.
Okay, and just to follow up on that, I read stories about hoarding, which in the overall scheme is inefficient. Do you have a sense of how significant that was in constraining total supply?
I don't know if hoarding was as big an issue for oxygen as it was really for medications. I think medications it was hoarding, and particularly for medications that were not, that are not even indicated for things like, ivermectin or remdesivir. Remdesivir, I think the demand was far greater than what the legitimate medical need was. But I remember, someone begging for remdesivir. I tried to explain to them that this was not a useful drug in the current situation of the patient. They wanted it anyway. The market price was about $7,000 or $8,000. We sent someone out to get it, and someone else had bought it by that time. And the actual price of this drug is, 100th of that or something. So yes, hoarding was an issue for drugs. There probably was hoarding for oxygen as well, but I think the oxygen situation was there really was a real shortage there. There was an actual calculated shortage, and maybe without the hoarding, we could have done a little better, but we couldn't have solved the problem without it.
And just a follow-up question on that. This is broader than just oxygen. This is coming from the audience, question by Pitch Johnson, who's asking about distribution and equality. When resources are constrained, who is most likely to get them? More generally, since India has a lot of inequality across gender, across ethnic groups, how equally distributed have COVID cases been, and how equally distributed are access to oxygen and hospital care?
Great question. First of all, you have to be wealthy and well-connected to get a bed in a hospital to begin with. Yeah. So to have an oxygen shortage problem, you need to be privileged. So if you didn't have that privilege, you probably died at home and just, died without oxygen. So you're right, that itself is a differentiator right there. But I think COVID itself, as I had explained, there have been waves of it that have affected different socioeconomic groups according to our data. We'll be publishing some of this again soon. But we have pretty good evidence that the initial sort of victims of COVID were the poor. It was brought in by the rich, transferred quickly to the poor in urban India, and they were the ones who suffered the most in the first wave. So there have been these disparities. And with access to care, I mean, come on, if you know anything about India, this is, that the health system, even at the best of times, is highly inequitable. And at a time like this, has been grossly inequitable to a point which one does not even want to dwell on. It was just horrible.
Yeah. By the way, there's another question from the audience, or really a comment from the audience that you can speak to at some point in this talk, which is there a way to help Ramanan with contributions for his oxygen initiative?
We always welcome that. Right now, we're trying to build an oxygen grid, like I explained, to make sure this never happens again. So oxygenforindia.org is the website. So oxygenforindia.org. And all contributions in the US are tax deductible because it goes through a 501c3. So yeah, we absolutely appreciate your help, and we'll make sure that every dollar is deployed to make sure that that people don't die because of lack of medical oxygen.
Can we switch and talk about the vaccines and the vaccine rollout? So I think that the numbers I looked at suggested that there's 250 million doses of vaccine that have been administered, with about 50 million people fully vaccinated right now.
Yep.
And I'm just wondering if you can just speak to how you have seen the vaccine rollout. What's the prioritization? Is it working? To what extent are supply side bottlenecks been present? To what extent is there vaccine hesitancy on the demand side, which is the issue currently in the US? Anyway, I'll let you speak about a collection of those topics.
Yeah, so India is, as you all know, is a big vaccine producing country. So it does supply, anywhere between half and 60% of the world's childhood vaccines. Overall vaccines, I would say it will be about a third when you consider all of them put together. And one of the reasons why India maintains an industry of that size is simply because India is also a big consumer of childhood vaccines. Roughly 1 in 3 children born globally is born in India. 27 million. It's the largest birth cohort, not just now, but it's the largest birth cohort in any country at any point in human history is in India right now. So India has some experience making vaccines. Now, where there was a big screw up was really in terms of not planning for the scale up and the need for vaccines for COVID, even though two companies, Bharat Biotech, which had a platform of four platforms that they're working on, a very competent company, and then Serum Institute, which is the largest vaccine manufacturer in the world. And these are incredibly good companies, I have to tell you. Serum Institutes, I mean, these are scale facilities that don't exist anywhere on the planet. They are really, really incredible facilities. So it would have not been a difficult matter for India to have made the investment at the government's level to be able to scale to make 2 billion vaccines for this year, which would have been sufficient to vaccinate every Indian, of the required age, and also export vaccines to other countries. Now, the information that came out of the public domain constantly from briefings was what was going on. In reality, that was not. So what happened was that by December, Serum Institute, which had spent its own money on putting together a stockpile, was forced to get rid of the stockpile because no one was buying the vaccine, because India had not yet placed an order till January. They ended up exporting 60 million doses. Of the 60 million doses, 55 million were actually commercial sales by them, either into COVAX or bilaterally to other countries. And 5 million were donated by India as a country to other countries. So although this was seen as vaccine diplomacy, nothing could actually be further from the truth. This was simply an Indian company trying to get rid of its stock by selling it to other countries, because otherwise they would have been left with expired stock on their hands. That's all it is. There was no diplomacy really there. The diplomacy is 5 million doses. And if you want to see the numbers, they're on the Ministry of External Affairs website. Now, as a consequence of the lack of scale up in production capacity, India was left, and even now, with a daily production of about 2.5 million doses. And 2.5 million doses is so small. Talking about effectively 2.5 million doses means 1.25 million people getting fully immunized every day. And if you're talking about a country with 1 billion people who need to get immunized, you could do the math and say that's going to take you 800 days. It doesn't take much more math than that. So 800 days is it's almost 3 years, right? It's 2.5 years. So that is, again, the math. At the current rate, it will take an incredibly long time. Now, so this is where the big challenge has been, which is entirely on the supply side. The demand side has not been a problem so far. The demand side was a problem in the initial stages with healthcare workers who did not want to get the Covaxin because they had not seen the phase 3 data. There have been missteps on the science. In fact, the article that was posted on from Foreign Affairs, this is where I really focus on, which is that India made the mistake that the US did, at least in the early stages, which is in not following science. And that is really what has cost a lot of lives in both countries. And not following the science has meant that approvals were given without adequate data. And what that also meant was that half health workers were reluctant to get vaccinated. I know many nurses who wouldn't get vaccinated, for instance. That said, vaccine hesitancy is currently not a barrier to vaccination, just because there's a lot of people who are scared of the disease. So you can have hesitancy about the vaccine, but you're seeing a disease that's much more deadly, and so you'll go out and get it. Vaccine hesitancy tends to go up when disease go down, the prevalence goes down. So undoubtedly, we will see vaccine hesitancy at some point in the future. It is not, it's not a binding constraint at this point in time. At this point, India's challenge is to be able to deliver enough vaccine doses, and India has the AstraZeneca vaccine, also Covaxin, potentially the Novavax vaccine, which is just announced as a results, is also licensed to be made in India by Serum Institute, so that would add to the production capacity there as well. But in order for India to get to vaccinating a substantial proportion of its population this year, and as the numbers you said, Arvind, there's about 4% fully immunized, fully vaccinated against COVID. To get that number to about 60% is going to take a 4 or 5x scale up of daily production. A 4 to 5x scale up of daily production is not trivial. It's a lot of adding production lines and quality. And the thing with vaccines is that if you make it too fast and poorly, you might have entire batches that fail and you lose millions of doses, as we saw for instance, with the J&J vaccine here in the US, where
Mhm.
a few million doses had to be thrown out because they were not made correctly. So vaccine manufacturing is a tough game, and particularly when dealing with inactivated virus, because you have to get precisely the right amount of inactivated virus into a vial, and it has to be inactivated enough. In fact, the Brazilians came back with a complaint about the Covaxin, saying that you've not properly inactivated the virus, which means that you're actually putting in live virus into people. So it's challenging to say the least. And last but not least is the fact that both the technologies that Indian manufacturers use are not as scalable as the mRNA technologies. So Moderna and Pfizer-BioNTech, their stuff can be made in a BSL-1 lab. It's quite easy to scale up. For India, for reasons that are still opaque to me, has refused to license these vaccines, is demanding that they drop their demand of getting a liability waiver in India, which they've got from the rest of the world. And frankly, I see the mRNA vaccines as the best solution for India to get out of this, because they have high efficacy and they can be manufactured at a scale that is consistent with what India needs. In the short term, this is the big constraint. In the longer term, we have other issues, which is vaccinating in rural India, hesitancy, and so forth.
So what would it take for India to produce the mRNA vaccines?
It's not a question of producing. mRNA vaccine is simple enough that the US could produce it for the entire world in large numbers. The US wants, the companies want three things. They first want that there's a liability waiver, right? So they don't want someone coming back and saying, there's a long-term impact of mRNA, give us money for it. They want that because they've got it in other countries, right? So that's first. The second is they want a central procurement of the vaccine, not by the states. And this again is something that India went back and forth on, is now back at center. So that problem isn't solved. The third problem is they don't want to do any bridging trials in India, and that seems reasonable given that most of the US has been vaccinated with these vaccines and things seem to be okay. I don't think there's need to waste another 3 months for the bridging trial in India per se. But I think overall, if the liability waiver can be dealt with, which I really firmly pray for, then I would really hope that most of the world can be vaccinated this year.
This year itself, okay.
Yes.
So so mRNAs from developed countries plus some of the small amount of local vaccine, and with that, it's feasible that by the end of this year we could develop. Okay. So that brings me to the next question, which is how you see this this wave or potentially another wave. What do you see as the evolution of this pandemic in India?
So the waves. So the waves are generally a function of behavior, right? So they're entirely a function of behavior. I think India, the government will be now once bitten, twice shy. Therefore, it will be quick to put in place restrictions as soon as cases start going up, which they inevitably will. That would be my hope, and that would be the sensible thing to do. So you either vaccinate quickly or you quickly put in place restrictions, and failure to do the combination of the two is what led to the second wave. And I would hope we would not see anything like that second wave again. So that's really the outlook. It's really all in the hands of state and central governments to being able to notice increase in cases and quickly sound the alarm.
And how, in that thinking, how do you account for, again, if I take some of the numbers you've suggested, say 40–45% of the population has antibodies just through infection, and then we're right now at say 5%, and potentially in the next few months maybe even 10 if you just count the local population of vaccination. Where does that leave you in terms of worrying about a risk of another wave?
So remember, the 10 is not additive to the 45. There's probably a lot of people who have had the same infection, same places, urban India.
Yes. Right.
The second thing is that the big uncertainty in India has been the new strains. And the new strains, we simply did not sequence enough to, although the people who were doing the sequencing did warn about the new strains of variants of concerns back in February itself. These concerns were not taken seriously. And part of the reason, if there is an excuse, is that the work to correlate these variants with transmissibility and lethality in the population, that work is always incomplete. So you can have a different variant, but unless you're able to establish as a variant of concern, you really need to establish that it's going to do more damage than what you had before. And I would hope that that science works out a lot faster now than it has in the past in India, not for lack of sequencing capability. You have to remember that India's problem is not lack of science. India has a lot of good science, a lot of good labs. It is the opening up and the academic freedom to deploy that science in the service of public health that has been the challenge throughout this pandemic. It has not been that India is not in the same boat as, say, a lot of Africa, for instance, just not having that capability at all to begin with. India has really good scientists and really good scientific capability. If we do that correctly, we can even head off for the new strains and new variants, pin down where those variants are emerging and respond very quickly, imposing faster lockdowns in those places and so forth. So all the tools to solve the problems of India all exist within India. It's just a question of leading with the science to be able to make that happen. And similarly with the vaccination, was it within India's capability to have vaccinated 50% of its population by now? Yes, India could have done it. I think someone wrote in the chat, you're talking about $5-6 billion in a country with 2 trillion plus GDP. It's chump change. It's the same way in which we responded with economic packages. It's just really small amounts compared to the size of the population. But I think what has failed is really it's a failure of imagination and how this has been dealt with.
There's a specific question here from Shivani Gaihai, which is, what has been the role of the Indian Council of Medical Research and the Public Health Foundation of India and other surveillance bodies in warning the government?
Well, the Indian Council of Medical Research is the empowered body to be able to do this work. And, in some cases, they've actually done decent research on saying, for instance, plasma therapy is not helpful. Or, in fact, one of the earlier models on warning about COVID also came out from ICMR. But somehow ICMR in its policy and leadership has fallen short significantly. Until a few weeks ago, maybe 2 weeks ago, it had allowed drugs like ivermectin and hydrochloroquine to still stay on the clinical guidelines, to allow plasma therapy to be allowed if physicians thought it was helpful. Now, I just don't see why that would be the case at all, because these should have been corrected a long time ago. And in the absence of good science and clear guidelines, I would say that if we review the pandemic in 10 or 20 years from now, what really didn't work out in India was really following the science. And I think ICMR has been, centrally responsible there in not bringing or allowing the best science to inform the response to the pandemic. And that is a huge failure.
Can I ask you to speak, I guess, in some sense about the world going forward as well as India going forward? There's a question here from Steve Denning, which is, what's the likelihood of India triggering a global resurgence of the pandemic in the fall, and in particular in the developed countries of the world who think they have the pandemic under control now?
The mRNA vaccines have shown themselves to be relatively robust to variants. So I think the risk of that remains low as far as what we know right now. Of course, all bets are off with respect to this virus if it evolves into a variant which then is able to get past the vaccines, and then we'll be in a very, very different situation. But keep in mind that even in the US, the vaccination coverage is highly skewed. The states with more than 70% of the population vaccinated all happen to be on the the northeastern seaboard, and then Maryland. So the rest of the country is not, vaccinated to the extent that it can. There's still too many people who are unvaccinated, and enough to be able to spark off large epidemics in the US and certainly in Europe as well. And to that extent, I think variants are a concern because people are not getting vaccinated. But I think over time, as coverage increases, and I hope it will, then we would have protected ourselves, relatively and adequately.
Can you also speak about other developing countries? I mean, you mentioned briefly Pakistan and Bangladesh.
I think the countries I'm most worried about, Arvind, are really in Africa, because I think countries in Nigeria, Ethiopia, Ghana, Sudan, DRC, they are facing the same sort of challenges of magical thinking about exceptionalism that India has also had. And once you get into that exceptionalism kind of thinking, then you think, oh, it's over there, it's not really going to happen over here. And that's really what causes, huge problems. So I do worry that Africa, with a fraction of the health systems of India, with a fraction of the ability to respond, and really vaccination coverages that are either extremely low or non-existent, are sitting ducks for this virus at this point in time. So we really need to pay attention to try to get most of Africa vaccinated. And, it's 500, 600 million people. We should be able to do it.
Yeah, so you mentioned vaccination. Are there other things that you would mention right now? If you could advise one of these countries, what would you say? Is it monitoring so that you can have a quick lockdown? I mean, the vaccination's presumably going to come in over time.
I think three things. One is I would get the oxygen supply in place, because that's where things go sideways. I would say a significant proportion of deaths in the last wave have been directly because of oxygen shortages. A second reason for deaths is simply because of healthcare facilities not being prepared or ready. A third is because of clinical guidelines. If you have clinical guidelines that emphasize, corticosteroids very early in a treatment cycle, which then dampens the patient's immune response and then leaves them susceptible to the virus itself, then you actually end up killing people who otherwise would have survived with more rational clinical guidelines. So the time to do all this is right now. Get prepared for these things. These are not the most expensive things in the world to get prepared for, especially the oxygen and the clinical guidelines. And if that were to happen, you can at least blunt the next, when a wave does come. And as you mentioned, being able to very quickly and responsibly lock down as soon as something happens is really the best approach. I'm not suggesting that lockdowns are, universally the best approach, but when you don't have any other tools, then this is the only tool you have.
Yeah. Can I just ask you then to just step back and just speak more broadly? How concerned are you in the world going forward about resurgence of these types of health events?
As you know, we've been warning about these kinds of health events for a long time, just because any day of the week or month, some virus is trying to jump, from animals to humans. Now, of course, in this particular virus, we don't know if it had help from a few humans in a lab, but maybe it did, maybe it didn't. But even so, the fact that we are constantly interacting with animals, that such a large proportion of the world's mammalian biomass is made up of animals that are very close to us. I mean, what I mean by that is the world's mammalian biomass is 30% human beings, but 60% pigs and cattle, and only 10% are all the other stuff, the tigers and the giraffes and all that stuff. So because we are raising so much meat for human consumption, that sheer concentration puts us at risk, because pigs, as far as their guts go, are not very different from humans. I guess some of us are literally pigs, but many of us are actually, quite close to pigs. So, flu virus typically emerges in a pig and then comes to us, or emerges in poultry and comes to us. So in many ways, the risk of this kind of transfer has increased because of the scale up in animal protein consumption. And the fact that we've not taken this stuff seriously, this possibility seriously. Apart from that, of course, is the idea of messing around with gain of function and so forth, which I think is something that really requires some international conventions to deal with. Okay.
We have come on the end of our hour, and we'll wrap up with that. Thank you very much for your time, Raman. This was very informative for me, and I hope for all of our listeners as well.